Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, Stephanie Desmond talks to Scott Becker, the Chief Executive of the Association of Public Health Laboratories. They discuss why COVID-19 testing has been so messy and what can be done to reduce the excessive wait times for results. Let's listen.
Scott Becker, thanks so much for joining me.
I'm so glad to be here. Thanks for having me.
So I want to talk about testing for COVID and where we are today. So I know that one of the major issues we're facing right now is the fact that it takes so long for most people to get their test results back that the results are basically useless for things like contact tracing and isolating. How did we get here?
Yeah, it's a really big problem right now. Here we are at the end of July, and in some ways it feels like we're back where we were in late March, but for very different reasons. So earlier in the pandemic, in March, the issues were collection devices. There were a lot of delays, and you just couldn't get testing. Now that we've expanded testing, the issues are a bit different. The testing process is really, really complex. I know people say that all the time about everything that they're involved in, but it really is very complex. It's a system. So, you first have to get the patient specimen collected using the right materials, getting it to the laboratory, then the lab doing the analytic piece, and then the reporting out piece. And there's so many different intricate moving parts in each of those things. So again, back in March, we had the problems with there weren't enough swabs. And there wasn't enough viral transport media, which is the fluid that the swab goes in and that goes to the lab, and then the RNA is extracted from that process in the analytics. But now we're finding a whole bunch of things. So number one, there's just huge demand. Yes, in hotspot states, but there's demand everywhere because people want to get tested so they can see their relatives, for example, or they're traveling someplace and they want to make sure they're not infected. And we also know there's a lot of asymptomatic transmission. So people want to do the right thing. And all along, people have been in the federal government in particular have said, if you want a test, you can get a test. And that really has been a challenge because we need to make sure we're using testing for the right reasons and the right purposes. And there's different kinds of tests for different things. I remember when the serology tests were first coming on the market. And the FDA sort of opened the floodgates very wide, and any company that wanted to market a serology test was able to do that. And said that was a really bad idea because we want quality. Well, serology tests are used for surveillance, really understanding what the seroprevalence is in the community. So it helps public health. That doesn't really help individuals. What helps individuals is the diagnostic testing. But now we have surveillance testing, screening testing, and diagnostic testing. And those are three different categories of testing. So we have demand, we do have supply issues. So the high throughput tests that are on the market from a number of companies that have a really good footprint of instruments across the country, they've ramped up, they've really expanded, and they've done what they could. And they're sort of at this point where they can't make any more. They are building production facilities, production lines, but those aren't going to come online, and we're not going to actually see those test cartridges and whatnot until probably late 2020. So, we're still going to be in this 6-month period of really constrained testing. There's
I'm sorry to interrupt, but the high throughput testing, that's the more rapid test, is that correct?
Okay, so there's different kinds of tests. So rapid tests tend to be the ones that are at point of care. So the Abbott ID Now is a good example of that. The Cepheid test, which is near point of care, so Abbott ID Now is 15 minutes and Cepheid is about 45 minutes. There are some antigen tests that are also very, very quick. And those are the ones that actually are just being deployed to the nursing homes around the country from the federal government. So and that's a good thing. We need those kinds of tests out there. So there's point of care tests, which are rapid. And then we have the more high throughput diagnostic tests, which are the PCR tests, the ones traditionally done in hospitals, clinical labs, commercial labs, and public health labs. High throughput really means getting the most number of specimens on, and through the system so you can do as much testing as you can. But those tests are in short supply. And what's even a little bit more in the weeds is a term we call plastics. So pipette tips, the plastic components for those test cartridges, those are also in short supply. So we're really in a tough spot right now. You asked me a really great question, which is, how do we get out of this? And I spent a lot of time thinking about it. I don't have a lot of good answers, but I have one really good answer, which is we all need to wear masks. We all need to distance, and we need to follow those general rules of hygiene. If we can do that, we will bring that curve back down. The curve that we speak so much of and the line we speak so much of is about ICU beds, hospitalizations, et cetera. It's actually also about test capacity. So we will be able to test as many people as we need to test if we don't have so much transmission by people who aren't following those rules. So it's actually really quite simple. That's a way to do it. We are not going to be able to massively ramp up production. If we started today using the DPA, we're still 6 months away. So the other thing we have coming up is the flu season, and that worries us a lot.
Those tests are easy and fast.
Those tests are generally easy and fast. That's correct. Those are the ones that you get at the clinic,
right,
the doctor's office. And many of those companies are now manufacturing, or they're in the process of getting an emergency use authorization, an EUA, for what is known as a multiplex test, which will test at the same time for flu A, flu B, COVID, and sometimes even RSV. So yeah, those are really important, especially for those of us in public health, to be able to differentiate between flu and COVID. If you have flu, you can get an antiviral. If you have COVID, antivirals won't help. And, there's other things, but test, trace, isolate.
So these testing issues, will they translate into the flu season as well? Are these companies sort of distracted by COVID and not able to produce flu testing, or is that not going to be an issue? I
am worried about that. I don't know the final answer on that, simply just because I don't know what's in the pipeline at the FDA. But the companies that we've talked to, and we've talked to very many of them, are pretty confident in what they can do, but they will not be able to meet the total demand if we keep going the way we are going.
Mm-hmm. And because I'm amazed at the rapid flu test, for example. I had the flu back in January.
Yep.
And, they gave me a test and they're like, well, you got flu B. It was just so simple.
Yeah.
And I know that took probably many years to get there, but I keep thinking why can't we have that for COVID?
That's actually where I think we do need to go. I think we do need to find cheaper, faster, much faster ways of doing testing. There have been a lot of innovation already. There's been the saliva test. And again, that has to go through an EUA, but that EUA lets us know that this is the quality review of that. We just saw last week the CDC posted its guidance on pooling testing, which is where you take 5 specimens, put them into one test that. If the whole pool is negative, those 5 were negative, if the pool is positive, you then have to pull that apart and then retest those individual specimens. But that is a way that you can get a higher quantity through. So large commercial labs, Quest, LabCorp, for example, just received their EUAs and they're moving in that direction, which is really good because they are a very important backbone for testing, because they're really the backstop for so many. And for this mass testing, that's not what public health labs do. So let me just mention, public health labs really are reserved, if you will, for high consequence testing. So in the earlier days of the outbreak, and it continues now, skilled nursing facilities, assisted living facilities, congregate living facilities, jails, agriculture workers, field workers, healthcare workers, that's really what we focused on. We focused on those high consequence cases and where you can, have a good chance of stopping that spread, which is really the goal. What worries me a little bit is the fact that there's such a need to do testing. Mass testing is not what public health labs do. Remember, we do a lot more than COVID. And it seems like we're becoming COVID testing machines, and that's not really our sole purpose. There are foodborne outbreaks going on in this country right now as we've opened up and as people are congregating. Public health labs are the primary laboratories that test for foodborne outbreaks. We have newborn screening tests. We test 97% of America's babies. Safe drinking water, beach water testing, so recreational waters, things like that. So we feel like we need to really continue that public health focus while other sectors, clinical labs, and others are really taking on that mass testing.
Are you able to continue to do those things, or are you overwhelmed with COVID?
I think we're trying to do those things. I think in many cases, there was a number of tests through March, April, and May, and even into June that we didn't see a lot of specimens. I mean, everybody was home, so you didn't have a lot of congregating, and there wasn't a lot of disease transmission in certain areas. But the other thing that we have been involved in is opioid surveillance. And, I think we're seeing a surge again of opioid issues as we open up. So we saw a huge downturn in testing earlier, but it's coming back. I mean, public health issues don't go away, and they aren't linear. We don't just see one issue and then another and another in sequence. We often see them together, and that's really what we're looking at.
I wanted to ask one more question about accuracy of testing. I know that you mentioned that the FDA sort of let whoever wanted to almost go online with some early testing. I know that there are false negative rates with these tests and some way higher than others. How are we doing with that?
So, the FDA did that with antibody tests early on, and about 6 weeks later, they completely reversed their course, which was a good move. So that's gotten under control. And every test that gets put on the market and is used by laboratories does go through an EUA. So that quality process is in place, and that's really important. The accuracy issue. So I think early on, there were some concerns about one of the point of care devices, and we know that FDA is working with the company on that. But what our members report is that they have generally very good concurrence between the rapid test and the PCR test that they do. So I think we're seeing a lot more comfort in using those kinds of tests. I do think that the FDA has been able to post what the accuracy, sensitivity, specificity is for different tests. So, consumer beware, know what you're getting into. The same thing with antigen tests. It's not, there's no perfect test. So there's nothing that is 100% sensitive, 100% specific at this moment. Especially there's nothing that is rapid, cheap, and in great quantity. That's where we need to go. And I really hope with the RADDX effort from the NIH, which is where, billions of CARES dollars went into. It's really an effort to speed up innovation in the diagnostics arena. There was just a New England Journal article that came out last week that was really terrific, explaining all about that. So I hope that folks can go and see that. I'm pinning my hopes on a lot of things, on not any one thing. So we're going to keep expanding testing. I believe there'll be innovation. I'm looking forward to seeing the results of the RADDX. The federal government is coming through, working with manufacturers to bring on additional lines. We saw that just recently. So I'm not going to end this with all doom and gloom. I think if people wore a mask, if they distance 6 feet or more, and use general good hand hygiene, we'd be in a much better place with testing. It isn't just about the testing. It's really about personal and social responsibility.
Scott Becker, thank you so much for joining me.
Thanks for having me.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.